So, targeted PCI, or should you just clear the roads? That's the topic. Data is escalating the debate between culprit lesion only versus complete revascularization, and we're here to look at what the ESC experience is. Management of non-culprit lesions in primary PCI, presented here in London, and I am with Professor Franz-Josef Neumann, who is an MD, medical director, and chairman of the Department of Cardiology and Angiology, University Heart Center in Freiburg, and Bad Krozingen in Germany. This is a highly clinically relevant topic, so let's talk about it in terms of what is happening over here, this side of the pond.
Well, I think usually the recommendation was the same as in the US, to do only the culprit lesion in the acute stage.
Right.
But now this concept was challenged by two larger studies, the PROMI trial and the culprit trial. And they both consistently showed that the outcome is superior if you do multivessel PCI in the acute stage as compared with culprit lesion only PCI. And if you pull everything together that you have in terms of randomized trials in this situation, so that's also two smaller trials and the culprit and the PROMI trial, then in this meta-analysis there is an advantage in terms of survival and in prevention of myocardial infarction on top of the advantage of saving the patient subsequent revascularization.
In terms of the relevance, we're talking about 30 to 40%, I think, of STEMI patients who have the infarct-related artery, but then they have other non-infarct-related arteries nearby. So where is it heading?
Well, I think the real question is it just the paradigm that you need to do complete revascularization, whatever type of coronary artery disease you have, or is there anything specific in the acute setting? And therefore, I think the next question is staged complete revascularization the same as acute complete revascularization, or it's even better to do staged. But I think the message is quite clear that we need to achieve complete revascularization, but the books aren't closed whether or not we should do it immediately or in a staged procedure, whatever.
Or a week or so.
Yeah, absolutely.
What do you tend to do? Do you follow the guidelines completely, or do you look around
and
go, wow?
Well, the ESC guidelines, they give a 2A recommendation for culprit and then staged complete, and a 2B recommendation for acute multivessel. So the guidelines leave it open, and I think it's more or less an individualized decision, depending on the clinical status of the patient, on the complexity of the other lesions. And so we do individualized decisions in our daily practice, and this is consistent with the European guidelines at least.
Who would you prefer going a staged route? Can you describe the patient?
Yeah, I would say, let's say, anterior myocardial infarction, and then very complex lesion, maybe a CTO in the right coronary artery and bifurcation in the circumflex. This is a classical patient for a stage procedure.
And what about someone that while you're there, you might as well get the work done and clear the highway?
If the patient is not complicated, and if there are simple lesions, you can do it right away without any problem. And this is also supported by PROMI and culprit.
Yeah, absolutely. So I think it's still a little bit debated, but apparently it's a little less debated on the European side of town. Is that what you're saying?
Yeah, we are less enthusiastic.
In terms of the debate?
Yeah.
Yes, exactly. Well, it's a great topic, and I thank you very much for spending some time with us, because this is certainly not going to go away anytime soon. Yeah. I'm sure there's going to be more studies coming up too. Absolutely. In terms of ESC coverage, please look around. We have been here for several days, and make sure that you get what's hot from ESC in 2015. I'm Executive Editor Rick McGuire.